What you need to know about transurethral resection of bladder tumors for bladder cancer. TURBT involves the removal of bladder tumors via any of the following: scraping, cutting, biopsy, fulgurating, or cauterizing. The bladder is made up of a few layers: the outside muscular layer, followed by the connective tissue or lamina propria layer, and then the inner layer is the urothelium. Bladder cancer is very common. It's the 5th most common cancer in men and the 8th most common cancer in women. It is most commonly related to tobacco exposure. 2/3 present with non-invasive disease, and 1/3 of patients present with more advanced disease. The staging of bladder cancer is related to the depth of penetration of the tumor. Superficial tumors are TA, T1 tumors, and go all the way to T3 tumors that extend through the muscle into the fat surrounding the bladder. Low-grade bladder cancers are the least problematic. High-grade bladder cancer tends to be very progressive and aggressive. With transurethral resection of the bladder tumor, a special type of instrument called a resectoscope, which is a cystoscope with a special device attached to it, is placed through the urethra into the bladder, and the tumor is removed in pieces using special instruments. To the left is an example of what a bladder tumor looks like, the fluffy pink tissue, and on the right is what the bladder tumor looks like post-resection with the base cauterized. The risks with TURBT include bleeding, but transfusion is only required in fewer than 1% of cases. Infection is a risk, bladder perforation is a risk, and this frequently would require a prolonged catheterization, infrequently requiring an operative repair. Injury to the sphincter causing incontinence or obstruction of the ureteral orifice, which are the insertions of the ureter into the bladder. When this occurs, it's necessary to place ureteral stents or drain the kidney directly with nephrostomy tubes. Chronic side effects of the procedure could include a prolonged bleeding in the urine or blood clots, a chronic urinary tract infection of the bladder or kidneys, or persistent urinary symptoms like burning, urgency, and frequency. TURBT usually takes only about 1 to 2 hours, and this will depend upon the size, location, and extent of the bladder tumor. This time also includes the time for anesthesia to begin and end the procedure. Most often, TURBT is performed as an outpatient surgery, and most patients go home after a few hours in the recovery room. Infrequently, patients are kept overnight for observation with or without continuous bladder irrigation. Patients usually leave with a catheter to stay in place for 1 to 5 days, which can be removed at home or in our office. Patients with a catheter in will go home with both a leg bag and a larger bag for nighttime urine collection. At the time of discharge, a physician will give patients prescriptions for narcotic to take as needed for pain, antispasmodic medications for spasms of the bladder, a stool softener, and sometimes an antibiotic. It's important to know that post-TURBT you can expect to have intermittent bloody urine for up to 4 weeks. You may urinate more frequently for several weeks, and you may have burning with urination. There's no immediate impairment in the ability to do activity, but you don't want to do strenuous activity for a few weeks because of risk of bleeding. It's important to increase your fluid intake for a few weeks after the procedure, and you can resume normal showering and bathing. Please call your doctor if you experience a fever greater than 101.5, chills, severe pain, the inability to urinate, nausea or vomiting, or significant amounts of blood in the urine, significant amounts of clots in the urine, and lightheadedness or dizziness. Please call your doctor or 911. Additional treatments will depend upon the final pathology after the TURBT. A pathology report usually takes about 3 to 5 working days to get back. The physician will either arrange a follow-up visit or call you over the phone to review your results with you. The procedure may be performed in the ambulatory surgery center. These are usually located adjacent to your doctor's office or in close proximity. They're designed specifically for outpatient procedures, but sometimes patients might need their procedure performed in a hospital due to underlying medical problems. A surgical scheduler will give you a date, and you may need medical clearance from your primary care physician or internist, including a history and physical exam. Additional testing can include blood work, an EKG, and a chest X-ray. You will receive a letter with all of this information about where and when to report. The pre-authorization process is essential. We will communicate with your insurance to determine your coverage and any co-payments or deductibles that you might owe. We will provide you with an estimate of any charges that you may incur, and all charges are due prior to the procedure. Payment plans can be arranged if necessary. In terms of preparing for surgery, you can have clear liquids but nothing to eat or drink after midnight. The hospital or nurse will call and discuss with you the medicines you can take the morning before your surgery. If you're taking a blood thinner like aspirin, Plavix, Coumadin, Xarelto, or Eliquis, please let your surgeon know, as they will likely need to take special precautions. Please never stop these medicines without discussing this first with your primary care doctor. On the day of the procedure, arrive early, at least 1 hour prior to the scheduled surgery time. The problem with bladder cancer is that there is a high recurrence rate. It does tend to come back after treatment. There's also the possibility of disease progression, and that the bladder cancer can invade deeper into the bladder wall and even spread to other organs. Blue light cystoscopy is a technology used to enhance the detection of bladder tumors. There are a number of benefits with blue light cystoscopy: better tumor visibility, more complete tumor removal, and a decreased rate of tumor recurrence. The risks really are identical to that of a regular white light procedure. With blue light cystoscopy, upon arrival, a catheter will be placed into the bladder. Cysview will be instilled within the bladder, and you'll be asked to hold your urine for up to 1 hour or more. Cysview is a colorless contrast solution that accumulates in rapidly growing cells such as cancer cells. It turns bright pink or red under a blue light. You can see here when the blue light is activated, the area of concern lights up pink. This aids in the doctor's ability to resect the tissue and diagnose bladder cancer. Both you and your prognosis and recurrence rate with bladder cancer are dependent on not smoking. Your risk of recurrence is much higher if you continue to smoke. You must stop smoking. If you need help quitting, there are multiple options to assist with smoking cessation: medicines, nicotine replacement, psychotherapy, and hypnosis. Please discuss with your urologist and, more importantly, your primary care physician if you need help quitting. For further information and support, you can contact the Bladder Cancer Advocacy Network, BCAN. We hope that your procedure goes as well as possible and that you have a speedy recovery. We appreciate your genuine feedback regarding your procedure, as we are always trying to improve the care that we provide our patients. Should you have any questions regarding your procedure or recovery, please contact your doctor. Thank you.